Prostate cancer is one of the most common cancers among men. According to the American Cancer Society 2022 statistics, close to 270,000 cases are expected to be diagnosed in the U.S. this year alone, and approximately 34,000 men will die of prostate cancer. Early detection is an important tool in getting appropriate and timely treatment. During this episode of Banner Health's Making the Round podcast, we're going to be discussing prostate specific antigen, or PSA testing, and what it is, what it means, and what are the outcomes in early detection of prostate cancer. We'll also be addressing some of the controversy around PSA screening and studies that challenge the risks versus the rewards of early screening. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. I'm your host, Christopher. With me today are Dr. Joseph Mashni, Urologic Oncologist, and Dr. Alex Bowman, Medical Oncologist, and the co-directors for the Genitourinary Multi-disciplinary Program at Banner MD Anderson Cancer Center at Banner Gateway. Thank you both for joining me today.
Thank you, Christopher.
Yes, thank you, Chris. It's a pleasure to be here.
Dr. Mashni and Dr. Bowman, MD Anderson and Banner MD Anderson Cancer Center recommends that for most males who are average risk for prostate cancer, a PSA test is recommended starting at age 45. I fall into this age category, and I've had discussions with my primary care physician whether I should be screened for prostate cancer through a PSA test. Dr. Mashni, what is a PSA test, and why is it important in early detection of prostate cancer?
So, Chris, the PSA test is a blood test. We use it to screen for prostate cancer, both to diagnose and also follow along after treatment for prostate cancer. It's not perfect. It can't say you have cancer or not, but it's a pretty good screening tool. You know, I get asked a lot of the time, what is a normal PSA? And I say it depends. You know, the only time is normal is when it's 0 and you've had your prostate removed. There's a lot of things that can affect the PSA level. We look at the size of the prostate, age, race, also take into consideration family history. You know, I've seen the PSA jump after a recent illness. We believe it goes up after an examination, a prostate exam. So with one abnormal PSA, we just don't jump at it. We take it into context, often recheck, consideration of all the little nuances of what a abnormal PSA is.
Dr. Bowman, this testing is not without some sort of controversy within the medical establishment. Can you speak about where this controversy came from and how's it affected the approach to early detection for prostate cancer?
Sure. So multiple different professional societies all offer slightly different guidance when it comes to when and how men should be screened for prostate cancer. The current controversy that we all kind of talk about really started back in 2012. And that's when a group called the U.S. Preventative Services Task Force, or USPSTF, which is an independent body of experts that's appointed by the U.S. Department of Health and Human Services, updated their prostate cancer screening recommendations to formally recommend against prostate cancer screening through PSA testing. This was based primarily on the results of 3 clinical trials, which had been read out recently. One of which showed that PSA screening did seem to actually improve outcomes and patient survival, and 2 trials which did not. Kind of the trial that had the biggest influence on this recommendation against screening was a trial called the PLCO trial, which was done in the United States, and failed to show a benefit in terms of overall survival when it came to prostate cancer screening. This trial had some fairly significant limitations, however, that ultimately influenced the USPSTF to make some revisions to its recommendations. Specifically, this trial was conducted in the United States, at a time when PSA screening was already widely available to patients outside of the context of the trial. So what that meant was that a lot of patients who were in the control arm, which had intended to not have the patients undergo PSA screening, still got their PSAs checked, usually through their primary care provider or some other means, just not through the trial itself. And if you look at the number of PSA tests in the patients who were intended to be screened, it was about 5 over the course of the trial. And in the patients who there was no intention to screen them, they still got, on average, about 3 PSA tests during the period of the observation the trial was looking at. So it was widely recognized that this was a significant limitation of the trial, as it wasn't really looking at PSA screening versus no screening. It really was looking more at an organized approach to PSA screening versus a more haphazard or kind of off-the-cuff PSA screening. And so based on the criticisms that arose from this recommendation and the limitations recognized in this trial, in 2018, the USPSTF revised its recommendations to now recommend shared decision-making for PSA screening in men aged 55 through 70. Other society guidelines, things like the American Urologic Association, the American Cancer Society, continue to recommend shared decision-making for men, usually between the ages of 45 and 55, starting between the ages of 45 and 55, and continuing until around the 7th decade of life. Shared decision-making in this context refers to the patient and the provider discussing the risks and benefits of PSA screening, and specifically the risk that some men will undergo invasive procedures such as biopsies, or potentially will receive treatment for lower grade prostate cancers that might not have been life-threatening if they had not been discovered. The converse of that, obviously, is that the risk for not screening is that some men with cancer will not be diagnosed until the cancer is spread, or it is advanced to the point that it requires more invasive treatments. Currently, MD Anderson recommends patients discuss with their providers prostate cancer screening with PSA testing and a digital rectal exam starting at the age of 45 and extending until the 7th or 8th decade of life, with screening typically stopping no later than age 85.
Dr. Mashni, the next question is for you. How do you diagnose prostate cancer, and what are some of the treatment options for patients who are identified as having prostate cancer?
So, Chris, to definitively diagnose prostate cancer, we need tissue, which means it's a biopsy. Most biopsies in the United States are done what we call transrectally. This is where an ultrasound probe is placed in the rectum, which is really close to the prostate. We're able to get very good imaging to be able to direct needles across the rectal wall. Though this unfortunately comes with the risks of bleeding and infection. Actually, across the United States, there's a 4% chance of infection. And some of those men get really sick, needing hospitalization, called sepsis. So we don't jump into biopsying lightly. This is also what Dr. Bowman mentioned and was considered by the U.S. Preventative Task Force. We do a lot of things to try to mitigate the infection risk. We ask about antibiotic usage recently. There have been different rectal and bowel preps that have been tried. Some places even swab the rectum to see if resistant bacteria strains are present. More and more places are going to actual transperineal biopsy, which is not through the rectum and does not have the same risk as transrectal biopsy. So if the biopsy shows that there's cancer, then we have to do the appropriate staging to see if this is just in the prostate or outside of the prostate. And if just in the prostate, we put it into kind of risk classification, where low, medium, high risk. If it's low risk, we often follow these patients along, called active surveillance, to make sure that best we can that there's not higher grade cancer there, In the intermediate and high-risk groups, we most often treat these patients. If it is just, again, in the prostate, standard treatments are surgery and radiation. Surgery, you remove the prostate seminal vesicles, and depending on the level of risk, we often remove the lymph nodes at the same time. These are the area, or this is the place that prostate cancer often first spreads. Surgery can be done open, or what's most often done now is robotic-assisted laparoscopic prostatectomy, which allows postoperatively probably a quicker recovery. Radiation is done in many forms. It can be done from out to in, called external beam radiation. Also done on brachy platforms, which is actually putting the radiation directly into the prostate. And then very precisely planned to include the whole prostate. There's a multitude of other treatments that are available as well. Cryotherapy has been around for a long time. HIFU, which more recently is becoming more commonplace in the United States, has also likewise been around the world for a good amount of time. There's always clinical trials trying to improve on treatment, and focal therapy being one of them, where they're just treating the area of the prostate cancer, not the whole prostate. All in attempts to take care of the cancer, but not have the side effects, which all treatments of prostate cancer have side effects. If the cancer is outside of the prostate, spreading to lymph nodes or bone, which is the most common places, then standard treatment is systemic. This usually first is done with hormone treatment as prostate cancer grows on testosterone. If prostate cancer has been found to be outside of the prostate, the standard treatment is systemic. Initially, this usually involves hormone treatment as prostate cancer grows on testosterone. There are other secondary hormone treatments as well as chemotherapy that can be used. This is where medical oncology, like Dr. Bowman, is involved. And sometimes, if prostate cancer has spread out and systemic treatment has been given, radiation and surgery are sometimes used adjunctly.
Thank you, Dr. Mashni. Dr. Bowman, Banner MD Anderson Cancer Center is unique in its approach to treating prostate cancer in developing a multidisciplinary team to identify, manage, and treat the patient who's diagnosed as having prostate cancer. Can you explain what that means and why is it important in patient outcomes?
Sure. So we have data to suggest that patients who, when they're treated in a multidisciplinary approach, meaning a surgeon, a radiation oncologist, a medical oncologist, basically a team of providers who are working collaboratively, that improves outcomes both in terms of survival and in terms of the patient experience. So one of the things that we think is very important here at Banner MD Anderson is getting a patient with a new diagnosis of prostate cancer into the clinic. And we try to do that into what's called a multidisciplinary clinic when we're able to. And what that means is that the patient kind of comes in and more or less simultaneously or contemporaneously sees a urologist and a radiation oncologist at the same time. And why that's important is that there are cases where surgery is the obvious answer, and there are cases where radiation is the obvious answer, but there are many, many, many more cases where surgery or radiation for localized cancer of the prostate could either be done and would have similar outcomes in the long run. And in most respects, the patient is really, choosing which of those two treatment modalities is the best fit as far as the anticipated toxicities, kind of what the schedule of the treatment looks like, what follow-up looks like, whether hormonal deprivation is going to be required. And so it's very helpful to have that conversation together where the patient can kind of get all of the options presented to them and make an informed decision. Medical oncologists like myself are increasingly getting involved earlier, even in cases of localized or non-metastatic cancer. And that's because we're increasingly seeing that kind of bringing some of the more aggressive medical therapies kind of to the fore is seeming to help in terms of reducing the number of prostate cancers that recur after treatment. So patients now are starting to be offered, in some cases, other medicines that help deprive the cancer of testosterone, or in some cases even chemotherapy, if we're really trying to make sure that their cancer doesn't come back after local treatment. In addition to kind of the core physician components of the team, we make sure that patients also have access to a variety of other providers who can assist with both their care and their rehab after treatment. So a lot of times we'll have folks see cancer genetics counselors because there are some inheritable syndromes that do predispose to prostate cancer and other cancer risks, and it's reasonable to look for those in the appropriate patient. Prostate cancer, or any cancer that requires long-term treatment, can have some psychological impacts. So we make sure psycho-oncology providers are there to provide for patients who may be, going through some mood issues or other consequences of their treatment as far as their psychological state. We do pelvic floor rehab. Obviously, urinary incontinence can be an issue for folks after a prostate surgery, and sometimes even starting that before surgery, something kind of akin to a quote unquote prehab, can help improve outcomes in the long run.
Thank you, Dr. Bowman. Dr. Mashni, what can a patient expect once they've been referred to the Banner MD Anderson Cancer Center PSA clinic?
Chris, our goal in developing the MD Anderson PSA clinic is to get you seen as fast as possible and at your convenience to find out if we do need to, if your PSA is normal or we need to look more into it. We then want to take the next needed measures and only ones that are needed to answer that question. Sometimes that ends up being another blood test. Sometimes it's imaging. At that time, we consider if you've had a biopsy, you need a biopsy. We'll also take in family history, if you've had recent antibiotics, other risk factors.
So Dr. Mashni, Dr. Bowman, simply what's the ultimate goal of the PSA clinic?
So Christopher, PSA screening, while not perfect, is a great tool to identify prostate cancer early. When we find prostate cancer early, it's treatable and curable. About 1 in 9 men will be identified with prostate cancer over the course of their life. Our goal for this PSA clinic is to be able to take into consideration all the little nuances of PSA screening, make it easy on the patient, partnership with the primary care doctors as well. If a person is diagnosed with prostate cancer, again, some we treat, some we do not, and watch along. The ultimate goal of the PSA clinic is to make it easy for a person to be screened for prostate cancer. And if identified, we have the tools that are needed for staging as well as for treatment to be done in a multidisciplinary fashion.
And what I would say about the PSA clinic here at Banner MD Anderson is, when you get a new diagnosis of prostate cancer, that's obviously a very scary thing. And in many cases, perhaps you're working with a urologist who's made that diagnosis. Perhaps it's just with primary care, who's kind of been the primary person taking care of you. But it can feel very lonely, and you can feel very confused about kind of what to do next. One of the advantages of this clinic is I don't think that there needs to be, any kind of uncertainty on your part as where to go or what to do. Everybody who you need to take care of this diagnosis, really no matter what diagnosis is found or what stage it's at, is under one roof. And there's really a very seamless process to get you in quickly with the people who you're going to need to see to figure out exactly what's wrong, where it is, and what you need to do about it.
Thank you, Dr. Bowman, and thank you, Dr. Mashni, for taking the time to speak with us today and educating us on prostate cancer screening, early detection, and treatment for patients that present elevated PSA levels to their physician. As always, we recommend that patients speak with their primary care physicians and have a conversation if PSA screening is right for you.
Thank you, Chris. Thank you, Dr. Bowman.
Doug, thank you very much. It was a pleasure.
And for our listeners, if you want to learn more about prostate cancer and the PSA clinic at Banner MD Anderson Cancer Center, please visit bannerhealth.com/cancer/prostate for more information. Thank you, and we'll see you next time on Making the Rounds.